Space Coast next to NASA and SpaceX. Today our patient is traveling to us from Boston, and you're going to see in just a moment with our x-ray machine that he actually has had a fusion done with cages at L4-5 and L5-S1. Now on his MRI I could see at L4-5 there appears to be a herniation that's still present in the foramen at the back of the cage. It's either herniation or scar tissue or both, and he appears to be having pain from that area. He has a cage at L5-S1. I don't see an issue there. We're leaving that one alone. And then he has adjacent segment disease at L2-3 and L3-4 with pinching of the nerves on the left side. We're going to get started. First thing I'm going to do is give him some numbing medicine. Dr. Deuk here. We're going to give you some medicine, okay? All right. So you're going to feel a little stick and burn. Yep, that's normal. It's just medicine going in. I apologize. Anyway, you can make them a little more comfortable. So, yeah, sorry about that. Just bear with me. That's just medicine going in. All right. Now, in just a moment, we're going to get our first x-ray and you'll be able to see what I'm talking about. Now, I told the patient that there's a chance we're not going to be able to get to this disc because of the prior surgery and all the metal, but I think we have a good chance and certainly going to try. All right, shot. Can feel we're in the right place, but hitting some bone there. Shot. Trying to slip around it. Shot. You stay still. Everything's okay. You having any pain? Shot. How's he doing? All right. We're in really nice trajectory for where we need to be. Let's get an AP view. So we're going to use the x-ray to navigate the needle tip to the herniation in the foramen. If you're looking at the side view there, it looks like we're going through the spine, but we're actually going around it. We're going through a natural hole. There we go. Looks good. That natural hole is actually the natural hole is called the neuroforamen. Hey, Jordan, let's show the audience the cage at L4-5. Now, the cage is just what we call paracentral. That's a T-lift cage, transforaminal interbody cage. And the herniation is to the left of that. Yep. Show them that area again with the arrow. The herniation is right in there. That's the foraminal herniation. That's what I'm after. And then we're going to show them the discs above. We're going to go for that disc as well to repair it and the one above that. Perfect. So here we go. I need to finish this. Are you okay? Shot? All right. So we're in the disc now. I'm up against the cage. I could feel it. All right. Now we'll take the. I'm going to make our incision. I'm going to try to do all three discs with one incision if we're able to do so. Just depends on the trajectory and the anatomy of the patient. I may have to do a second incision. Shot. I'm aiming for the L3-4 disc. Shot. How's he doing, doctor? Good, thanks. Shot. So far going well for our patient. No issues. Shot. Is actually able to get into that 4-5 disc easier than I thought. Let's get an AP view. You can see the needle tip is at the foramen now at L3-4, just above the fusion. And you can see the MRI down in the corner, what we're dealing with, which is adjacent segment disease. Are you awake? Are you comfy? All right, good. All right, so you can actually see the herniation on the x-ray. Show them the herniation on the x-ray. You can actually see it bulging out back there. Yep, that's it. Good job, Jordan. I feel like Jordan is kind of my Vanna White, you know? Shot? I can feel the herniation. Good. One more to go. I don't think I can get this last one from here, but we'll try. We'll try. We'll try. Let me just try. Try to do it all with one incision. This is a Band-Aid incision, folks. We're doing complex spine surgery, endoscopic surgery, with a Band-Aid incision. Pretty remarkable. Only because we have the endoscope, we're able to do this. It's a bit of a stretch. And it's not that I can't reach it. I want to make sure my angle of attack is going to be good. I don't like it. So I'm just going to do a second incision. I've already numbed the area up. Shot. 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 You know, it's more important to make sure we get the surgery done properly than to have less incision. So I want to make sure we get this done properly for him. Shot. Now what's remarkable is his old scar, shot, was, I didn't do his original fusion. Shot. It was done, I don't remember where he said it was done. Do you remember? Shot? Anybody remember where his fusion was done? Was it in Boston? Are you okay? Shot? Everything's okay. You're doing great. Could feel that herniation. It was calcified. Shot? All right. So his surgery was done, I think, in Boston. And he had a fusion done. Let me just show you the scars. Actually, it's harder. Yeah, there we go. So his scar is literally right here. Right there. And the other one, they did two sides. They did another one there. So that's his scar. The problem is that the fusion was done down here. So they didn't put the incision in the right place, but, you know, they were able to do it. That may be why he's having some problems. Okay, so we have 3 discs that we're going to be looking after today. This is the L2-3, the L3-4, and the L4-5, which is down here. All right. Are you comfortable? All right. We're going to put you to sleep in a few minutes. Just hang out for a second. No pain right now? All right. Just lay still. Don't pick your head up, all right? How bad is that on a scale of 1 to 10? 10? Is that where you typically get back pain? Okay, sorry about that. That's the 10 over 10, concordant, and that's L3-4. Sorry, we just had to test it to make sure it's the cause of your pain. Is it better now? See? The discogram is a great test to see whether or not a disc is causing pain. Jordan, show them on that side view x-ray. Henry, go to the x-ray again. You can see the herniation. It's sticking out. Yep, there you go. A lot of the dye coming out there. You comfortable? Yeah. All right. How bad is that on a scale of 1 to 10? What number? How bad is that? 10? Is that where you typically get your back pain? All right, so we tested L2-3, it's a 10 out of 10. L3-4 is a 10 out of 10. So we know that we've got 2 discs that are definitely causing a lot of pain for him. And Because I'm concerned about the L4-5 as well, I'm going to go take a look at that one. I don't think we can get a discogram there.
Okay.
Well, let me just see. Are you comfy?
Yeah.
All right. We're just inside, but I don't know that we can get this discogram. Is that bad? Shot?
Yeah.
All right. So how bad was that last one on a scale of 1 to 10? 9? So he had a 9 out of 10 pain, folks, at L4-5. That's where his fusion was done. That's why we don't do fusions. They don't work. If they're done by most doctors, they don't work. What is it? I can't hear you.
Which one do you want?
You tell me.
2, 3, 4.
I say 3, 4 first. Yeah. Yeah. 4, 5 is going to be a very interesting one. Just so you all know, I've never done a laser at a level where there's been a fusion done. That's because fusions normally take the disc pain away, but not in his case. The fusion didn't work. So anyway, let's get the lights down and let's get the show on the road. Is he asleep? Shot? All right, we're putting our guide wire in. I'm going to take the needle out and we're going to leave the guide wire in. Go ahead, Luis. And then we're going to bring the dilator down. This is the dilator, by the way. It looks like a long, skinny pencil made out of metal. Wonderful stuff. And it doesn't cut anything. It just spreads. And that's kind of the point of the surgery, is it spreads the tissues rather than cuts them. How long were you in the hospital for with your fusion? How long were you in the hospital for? I didn't ask him before surgery. But most people are in the hospital a few days with fusion, sometimes a week or longer if they have complications. So, all right, you can see that the fusion has caused the 2 discs above to wear out. We call this adjacent segment disease. And he did not want more fusion, that's for sure, especially since the other one didn't work. That's the problem with fusions, folks. You might have a good result for a little while, but then the pain comes back above or below the fusion. That's why we don't recommend fusions anymore. Fusions are an old technology, but they're still being done by 99% of surgeons because they pay really well. You make a lot of money doing a fusion. We don't do this for the money, we do it because it helps patients. And the laser surgery is a far better procedure. All right, Dr. Berndez, good job. Maybe we gave you some good disc numbing, huh? Some num-num? You happy about that? So it's good. All right, now, the rest of the surgery will be done with this single little metal tube. It looks literally like a straw, you know, like a shake straw. So what kind of shake are you thinking about right now? Let's get a poll. Chocolate. Vanilla.
Strawberry.
Strawberry. Are you just saying that to be different?
No.
What are we talking about? Sorry.
The type of shake.
Oh, type of shake. I don't know. Oh, I like mint chocolate.
Mint chocolate chip.
What?
How about you? Chocolate. I say chocolate. All right, looks like the chocolates win. So we're all thinking about chocolate shakes when we think about the shake straw that we're putting in right now. Shot? Okay. So the chocolates take it. Now vanilla's good too. My wife is a vanilla person. You guys ever go to Shake Shack?
Yeah.
That's good. All right, folks, so we're going to start with the L3-4 disc. And I'm really happy to see that it was causing him 10 out of 10 pain, because that pain is now going to be gone for the rest of his life. It makes his trip here to Deuk Spine Institute from Boston worthwhile. All right, any questions from our audience yet, Henry?
We have a couple of comments.
Wonderful. I love comments.
The first one comes from Sheila Lateson on YouTube.
Hi, Sheila. Welcome to our broadcast.
And they said, I'm awaiting surgery, L4, L5. I have numbness down my left. leg.
Okay. Well, I hope your surgery goes well. You may want to consider this surgery instead of the surgery you're having, if you aren't having it here, because if I am correct, your surgeon is going to do what's called a microdiscectomy. A microdiscectomy. And microdiscectomies are bad. We don't do them anymore because they're so damaging. What I mean by that, folks, is to get down to the disc with a microdiscectomy, you've got to take a lot of the normal pieces of the spine out. You have to open up the spine. And that procedure has been doing for 100 years, way before we had more advanced technology. But there's a lot of surgeons who still do microdiscectomies, especially older surgeons. And it's a horribly destructive procedure because it leaves the spine in a weakened state. We call it an unstable state. And a lot of people that have microdiscectomy, by the way, this is a piece of herniation, they end up coming back for more surgeries because the original surgery, the microdiscectomy, requires the surgeon to remove the joints, the stabilizing joints of the spine. Let's show this herniation.
Lights on, please.
Can you see this, Henry? Let's turn the light on. Put your napkin there.
We see it, yep.
Yeah, so there's a piece of herniation right there. Now, when I put the dilator in, it shoved it back into the disc through the tear. You can see with the Deuk laser disc repair, we're not removing any bones or ligaments from the spine, normal bones or ligaments. We're only taking out the herniation. The rest of the spine is left alone. And this is why you want this procedure. This very reason. There's no damage done to the spine to get there. Now, microdiscectomy is very damaging. Let's go ahead and show people, why do patients get back pain from a herniated disc? What causes the back pain?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging
The piece I just pulled out, can you guys see this? I've been taking out little pieces of it, but this is the last piece I got out. We've been working on that. That's a piece of herniation, folks. That's the big herniation we saw at the beginning in the foramen. Now it's gone. All right, I'm going to bring the laser in now. You can see the end plates. And the source of pain is right up here at the 12 o'clock position. This is the annular tear. It looks like another piece of disc there I got to get. All right, so let's, if we don't have any questions right now, let's show our audience, what does this surgery actually do? How does this surgery work? So they can understand it with the video.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. You can actually see how the Deuk laser disc repair works. And it works because we remove not just the herniation, but we clean the tear the herniation came out of. Here's another piece of herniation, another big one. It's coming out in pieces. Some people are surprised to find out that a herniation is not just one event or one piece, it's multiple pieces over time. And that's exactly what happens when you get a herniation, is you don't just have one episode where it happens and you're done. It actually happens little bits over time usually. There's another big piece of herniation right there. So what we found here at Deuk Spine doing endoscopic surgery on the discs is that most patients have about 20 pieces of herniation per disc that's herniated. And we just have to get in there and remove each one. Now this patient's had back pain for, I want to say, over 20 years, if I remember correctly. And nobody's been able to fix it for him. And his life is completely destroyed by the back pain. His daughter is here with him. She's accompanied him and taking care of her father. It's wonderful to see. I still have teenage children. They're you know, working on taking care of themselves first, and then they can take care of somebody else. All right, this is the annular tear I was talking about, and you can see it in the video. This annular tear is where all their back pain comes from. And that's what we discovered here at Deuk Spine. That's why you don't find this procedure anywhere else, because it was pioneered and discovered here at Deuk Spine, the cause of back pain. And I get this question quite a bit. Dr. Deuk, how do you know what causes the back pain? The answer is quite simple. It's all about probabilities. And probabilities are the chance that something is going to happen in life, right? So everything that happens in life, all events, have a likelihood or probability of it happening. And the likelihood can be low or it can be high. It could even be 100%. Right? And so when we talk about likelihoods, if you take a quarter, like a coin, like a quarter, it has a heads and a tail, right? And you flip that coin, you have an almost 50% chance that it's going to be heads when it lands, and an almost 50% chance it's going to be tails with a normal flip. There is still a small chance that it'll land on its side, and it'll be neither heads nor tails. But you could pretty much say that the chance of heads is 50%, the chance of tails is 50% when you flip a quarter. Now, when it comes to back pain, it's not a 50-50 chance of one cause or another. The causes of back pain are very well known at Deuk Spine, and the most common cause by far is the herniated disc or degenerated disc. Herniated, degenerated disc. Basically, the disc. And the damage to the disc is almost always the same. It starts with a herniation. It starts with an annular tear, I apologize, and that leads to a herniation. And the herniation of the nuclear material, the blue stuff you're seeing right here, this is what causes the inflammation, and it's the inflammation that causes the pain. We're in the more painful part of the disc right now, Doc. That may be why he's responding a little bit.
We have a couple questions.
Hold on a second. So what is the chance that if you have chronic back pain, it's coming from a annular tear? The answer in our experience at Deuk Spine is 85%. 85% chance that somebody with back pain, it's coming from a disc or two. Now, there's a smaller chance, about, almost 15%, that the back pain is, I need a laser, is coming from a facet joint. Now, the facet joints are small joints in the back of the spine, and they definitely cause pain in many people, but they only account for 15% of chronic back pain. So the vast majority of chronic back pain is the disc, a damaged disc. Like this disc right here, and specifically the annular tear, which is what I'm working on right now as we speak. Now, that there's about 2 or 3% of back pain that comes from something other than the disc or the facet joint. What else is there besides the disc, which accounts for 85% of back pain, or the facet joint, which accounts for around 12% of back pain? What else is there? And the answer is there's the SI joint, sacroiliac joints. There's fractures of bones, which are pretty easy to see on CAT scan. That's another piece of herniation right there. And there's, piriformis muscles, which are common cause of back pain. And then there's the coccyx ligament. Whew. So I shoved all these herniations back into his disc, and now we're fishing them out. Pretty cool. I think that's the last one. We're just about done with this level. Yep. I don't see any more. I don't feel any more. We've debrided the annular tear nicely, and we've gotten rid of the herniations. And I'd probably hit that tear one more time with the laser, and we should be done. We'll take the questions now.
All right. First question comes from Saul Sotelo on YouTube.
Hello, Saul.
And they asked, I sent my scans to you guys about a week ago. I understand that the hurricane was horrible. How many days did the storm put you guys behind?
Oh, it put us, Sam Sotelo, or the storm put us probably 2 full days behind. So, but yeah, be patient. The free MRI review is just that. You're getting a $1,000 consultation for free. And we have a lot of people that want that MRI review, and we get around, at least 15 requests a day for free MRI review. So just be patient with us, and you should hear something from my team. Specifically, Sam is her name. She'll be reaching out to you, Sam, and she's the one who will schedule your free consultation once we get your MRI. You can reach Sam at 321-775-1299. 321-775-1299. We'll go ahead and put that phone number in the message there, so you can call Sam and ask her, hey, what's going on with my MRI review? But just, be nice to her. She's got a lot going on, trying to catch up after the hurricane. All right, next question.
Next question comes from Angelo Rivera on YouTube. His next two questions are from Angelo Rivera on YouTube.
Hello, Angela, YouTube. Thanks. Welcome to our live stream. All right, we're done with this disc. I don't see anything else that needs to be debrided. It's nice and clean. We got rid of the herniations. So we're done with this disc. All right, go ahead and give me the questions from Angela.
from Angelo. He asked, what's the magnification of the camera, and does it vacuum the damage out as well as being pulled out? And also, can the laser damage anything else?
Woo. That's a lot of questions. Let me try to take those one at a time. So let's ask me the first question.
What's the magnification of the camera?
Yeah, great question. What's the magnification of the camera? I'm going to go back in a moment and I'll show you. The laser fiber, which is that blue thing at the top, that laser fiber is 1/2 millimeter, the glass part, 1/2 millimeter. So a millimeter is very, very small, and it's quite magnified. So you can use that as a reference. The glass fiber of the laser is 0.5 or 1/2 millimeter. The entire inside of this metal tube that you're seeing is actually 6 millimeters. 6 millimeters. That's a small amount. So we'll look at that in just a moment, okay? I just got to come out. Here, take this. Come on. Come on. Pay attention. We're going to get the fluoroscope back in, and I'm going to go to the next one, which is the L2-3. Remember, we tested the L2-3. It caused 10 out of 10 back pain. That's his typical pain. That's where he typically gets it. L2-3 and L3-4 was 10 out of 10. We're going to do L2-3 disc next. We're going to save the cage disc for last. That's the disc that was already fused, L4-5. He had that done by another surgeon somewhere in Boston, I believe. And that disc is still causing his pain, which we found out today. It was a 9 out of 10. All right, you can see on the x-ray that we just finished the L3-4, showed them the L3-4. It actually looks better on the x-ray. And now we're going to go to the L2-3. Okay? All righty then. I need pressure here. Probably a little lower. Let me see. Good. Hold pressure there. Yep, right there. Right where the muscle would be. All right. So can I get the light on here? We're going to make our next incision. You can see we're using an 11 blade. We're going to do what's called a stab incision right along the shaft of the spinal needle, and that's a 7 millimeter incision. The reason it's 7 millimeters is that's the outside diameter of the... What's wrong? Yeah. Yeah. Hold that. Shot. Good. We're going to remove the spinal needle. Hold on, shot. Somebody move the patient. Please don't move the patient. Shot. All right. Shot. Good. Once we get the spinal needle off of the guide wire, then we can bring the dilator down. Shot. Very good. All right. Shot. Uh-huh. Perfect. Shot. All right. Now, let me see what we got here. Good. So, he had a lot of scar tissue from his fusion there. We're going down the guide wire. Remember, the guide wire is creating a safe pathway for my metal instruments. Otherwise, I wouldn't know where I am, right? Because I can't see where they are. So you use the spinal needle to guide yourself to the right location, and then you run the guide wire inside the spinal needle. It's not anything I developed. This is something that was taught to me. This use of guide wires and needles is very common in spine surgery and minimally invasive technology. Yeah. I was trained on the very beginning of minimally invasive techniques in my neurosurgery training at the University of Florida in Gainesville. in the Department of Neurosurgery back in 97 to 2004. That's where I spent my 7 years of training and my fellowship. And then I learned the endoscopic surgery, the stuff I'm doing now, the basics overseas in South Korea and from Germany, where the pioneers originally were. And then, of course, there was an American surgeon, Dr. Anthony Young, who taught me a lot about lumbar. And then I had to pioneer cervical, mostly myself, and thoracic I pioneered as well, here at Deuk Spine. All right, let's see. What other questions does our audience have at this time?
Yes, following from Angelo Rivera's question, the magnification of the camera, and does it vacuum the damage out as well as being pulled out?
Yeah. All right, great question. So the damaged tissues float out because we use irrigation. Take a look at this right here. Can you see this?
Yep.
This is an irrigation line. It's got sterile saline in it. When I turn the knob, look at the pressure. And then when you put that down in the tube, it actually pushes all the debris, the little pieces of disc that are blasted with the laser into little pieces. It brings those pieces up and out. So they're really floated out. Pennywise would be very happy with what we do here. Pennywise likes floating things. Anybody know who Pennywise is?
From the movie It.
Huh? From It, that's right. The movie It, the book It, I should say. A book written by Stephen King. Actually, my favorite author. You know, his writing is just incredible. He calls himself a narrator because he narrates stories. Of course, he creates the stories that he narrates, but he's quite the narrator. If you've never read Stephen King, I recommend it. He's been writing books since the 70s. And if you want to know who my favorite author is, that's him. There's a herniation right there. You guys see the blue thing? That is the nucleus pulposus. For those spine buffs out there, the nucleus pulposus is the jelly in the middle of the disc. And we're about to take it out because that's a degenerated piece of jelly. Look at it. It's stained blue. It should not stain blue normally. It would be white. The only reason it's staining blue is because it's degenerated. And the reason it's degenerated is because of the inflammation of this disc. The pain and inflammation going on in here has changed that nucleus from white to an acidophilic material, which stains with our blue dye. So normal nucleus is white. It doesn't stain blue. And degenerated nucleus from the herniation stains blue. So we want to remove as much of that blue stuff as we can safely, because that's the bad stuff. That's the herniation. All right. How's he doing, doctor? Now here's a calcified piece of disc right there. See how it turns a golden color with the laser? So you were asking about scale. You see that little glass tip right there? I'm moving it around. That is the laser fiber. It's made out of glass. It's 0.5 millimeters in diameter, half a millimeter wide. The inside of the tube from left to right, the diameter of that tube is just under 6 millimeters. It's like 5.8 millimeters. Let's just say 6 millimeters. And you know how small a millimeter is. It's very small. So that's your magnification there. We're dealing with very small, submicroscopic, because the magnification of the endoscopic system we're using is better than a microscope. We've even seen single blood vessels coming out of capillaries. I'm sorry, not blood vessels, red blood cells. I've seen red blood cells with this scope. Like if I zoom in, you can see the little red blood cells, each one coming out of the capillary. Now, there are different kinds of microscopes, as you all know, and there's everything from operating microscopes, which is what we use for spine surgery. We have an operating microscope here at Deuk Spine Institute. It's a Zeiss, spelled Z-E-I-S-S, German-made microscope. It's a big microscope. It's as big as a, I don't know.
Small refrigerator.
Yeah, a refrigerator. There you go. It's as big as a refrigerator. The microscope is. Now, there are also microscopes that people use in labs to study cells. And there are special microscopes called electron microscopes that allow scientists to look at virus particles and really, really small things, okay, that are considered submicroscopic. They're still called an electron microscope. The microscope we use here in the operating room is a big thing, size of a refrigerator, and it's made by a German manufacturer called Zeiss. Now, we're not using that today. We use that for our ACDFs and microdiscectomies if we ever do them. We're using an endoscope, which is different. An endoscope is kind of like a microscope, but you put it inside the body using a system of tubes. So the magnification of the endoscope is better than a microscope, and you see more detail with this surgery than you do with a microscope, which allows it to be safer. Now, is the laser dangerous? It is dangerous, absolutely, if it's misused. But if you're trained on the laser, like I am, and you have a lot of experience using surgical lasers, like I do, for many years, then you can use it quite safely. These lasers are not just brought in to the operating room willy-nilly. They're literally FDA approved for use in the operating room. They're medical lasers. They're supposed to be used in surgery, just like we are. So our laser is FDA approved for use in the operating room for spine surgery. Unfortunately, most surgeons don't know how to use lasers, and they don't have the endoscope or the endoscopic skills to use a laser. So the surgeons that badmouth lasers, they're not endoscopic spine surgeons. They're just regular spine surgeons, run-of-the-mill, and they don't know how to use a laser properly, because you have to use it endoscopically to use it properly, and they don't know how to do that. So you're not going to get many spine surgeons wanting to do laser because they don't want to do endoscopic surgery. And I'll tell you why they don't want to do endoscopic surgery. They know about it, they just don't want to do it because they're too busy putting in metal plates and metal screws and making a lot of money doing that off of you, the patient. So you can't put screws and plates and metal with the endoscope. So basically, if you're going to do endoscopic surgery, you're going to do minimally invasive surgery. That's better for the patient, safer, but we can't put metal in. And there's really no need to put metal in because we're not destabilizing the spine. The problem is when you do open surgery, like a microdiscectomy or a fusion or an artificial disc, those big incisions, they lead to damaging the spine. And when the spine gets damaged, it becomes unstable. And that's why the surgeons have to put in metal, because they're making the spine unstable with their surgery. Did you know that? The surgeons are the reasons they have to put metal in. It's not that they're going in to fix something that needs metal, it's they're going in causing the need for metal. And most people don't know that, unfortunately. So they happily go and get metal put in by their spine surgeon when they don't need to. Listen, I was just as guilty as the next guy or gal, because for years that's what I was taught to do, put metal in. I was a big metal surgeon for many, many years. The first 15 years of my career, once I graduated, first 20 years of my career, if you count my training. And I've done over 1,000 fusions on the neck and 1,000 fusions on the lower back. I've even published as an expert in the world on fusing in the lower back. So that's how involved I was in doing, you know, maximally invasive surgery. And then I learned the endoscopic technique 16 years ago, halfway through my career, and I brought this technology back to the United States and improved on it, made it better than what I saw overseas. And now we've been doing this for 16 years here at Deuk Spine. We've done over 1,500 patient surgeries, and our success rate is higher than fusion. We're able to get rid of about 98% on average of back pain and neck pain. All right, just about done here. I feel him starting to wake up a little bit. We're going to do one more disc. I need about 30 seconds on this one. All right, what other questions can I answer? So I tried to answer the laser question. The laser is dangerous if you don't know how to use it. But for me, it's not dangerous at all because we're using it in a liquid medium that's cooled. It's a cooled liquid, and it keeps the laser cool. It keeps the tissues cool. You don't see any fires down there, do you? If there was any sparks or fires, you would see them. And that's because there are none. The laser is extremely safe when it's used by a highly skilled, well-trained surgeon like myself. Okay? You have nothing to worry about. It's the best surgical instrument there is for endoscopic surgery. Now, you don't need a laser when you're doing non-endoscopic surgery. If you're doing minimally invasive surgery, you need it. If you're not doing minimally invasive surgery, you don't need it. But there's no way to do this surgery without the laser if you want to do it minimally invasive. Okay? That's just that simple. All right, the herniation's now gone. We're done. We're going to clean this out with a little antiseptic. What other questions do we have, Henry?
Other than for Angelo's questions, if the laser can damage anything else, I believe you just answered that. And then we have a comment from Sheila Layton on YouTube, coming back from her surgery L4-L5. She replied that, yes, my doctor is doing a decompression of my L4-L5.
Thank you. Well, you could have this done instead. Is it Sheila?
Sheila, correct.
Sheila, you could have this minimally invasive procedure done instead of that open surgery. I stopped doing those. No, I need to suck it out first. Come on. Go through your head what needs to be done, and then you'll do the right thing.
I had it right next to me, sorry.
Yeah, we stopped doing the open decompression, Sheila, because, like I said, the surgeon is going to make a big cut and scar tissue and bleeding, and ultimately when they get down to the bone, they're going to start taking your bones and ligaments out of your spine. Normal bones and ligaments, ones that you don't want taken out. And the only reason they're taking them out is because they don't know a better way to do it. So that's their way of doing it. That's the way we've done it for 100 years as spine surgeons. But there's better ways now. Your surgeon just doesn't know how to do that better way. So they're going to do the old-fashioned way, which, you know, hopefully will work. I can tell you right now, decompressions, whether it's a laminectomy or a microdiscectomy with a laminectomy, they don't cure back pain. So if your primary problem is back pain, you're probably still going to end up having it, and it's going to get worse. What they do with that procedure is they're trying to fix your leg pain, which is from a pinched nerve. Leg pain. So just be aware of that. If you're having a lot of back pain, a decompression is not the right surgery. Okay? Just trying to be helpful to you. I hate seeing people have surgeries they don't need and that don't help them. And there's a lot of people out there that get surgery that doesn't work on their spine. And the reason is the surgeon doesn't do the right surgery. They do the right surgery for themselves so they can make their car payment or house payment, but they don't do the right surgery for the patient. Okay, so we did actually do a discogram at this disc. You could see the cage and you could see the guide wire going right into the back of the cage. But this disc is not normal and this disc is not fixed. The surgeon that did the fusion was hoping to get rid of their pain here, but we just tested this disc and it's definitely causing a lot of pain for this patient. I think it was a 9 out of 10. Shot? Alrighty. So, pressure. We're gonna remove the needle once again, and we're gonna be left with the guide wire. Be careful when you do that, you don't pull the guide wire out. Shot. Now this is gonna be a little different. Why are you doing that? Why is it doing that? Are you adjusting the collimator?
I have no metal correction, so it's
Oh,
lowering that out. I think it's lower down.
no worries. I just thought you were playing with the collimator for some reason. Shot? Okay. So here we are now at the back of this already instrumented level, which I'm not sure if it's fused or not. I'm going to be really careful with advancing this dilator because I'm not going to be able to go in as far as I want to normally. I'm just going to go to the back of the cage, and I'm going to try to remove some of the herniation that's here in the back of this cage, because the surgeon either left some herniation here or probably a lot of scar tissue here too. Shot? All right. Take that. Don't do anything yet. I want to feel this. All right. Take it out. I can feel the cage right there. You guys hear the change in the pitch? You heard that? So we're going to go take a look. I'm not going to be able to get much out of this, but we're going to try to get what we can out because I know it's a painful disc. He may have to have this refused at some point. Shot? If I can't get it fixed. That's probably the best we're going to do. Keep that down there. Yep. Let's take a look, see what we can see. So, you can see we're at L4-5. We're right at the back of the cage on the left. And what I saw on the MRI is there's still some herniated disc there. I'm not able to get in any further because the cage is blocking us. Now, I wouldn't even mess with this level if I didn't think it was causing him pain. But when I examined him in clinic, he pointed at this level as well and said it was painful. And when I just tested it with the discogram, it was painful. So I want to see what I can do to help him out, if anything. Oh, there you go. There's some herniation right there. So we'll get that out and see if that helps. Hold this tube here. I need you to hold this tube. Hold it down so it doesn't move. There's a piece. And you're going to hold that tube there. Don't let it come up.
Yes, sir.
Okay? Yep. Thank you, Oscar.
Yes, sir.
Any questions? So you're seeing a first, because I've never gone in at a fused level before, but this is all a herniated disc. So it's a good thing we actually did it. All right, going in. Now if it was scar tissue, hold it there. If it was scar tissue, it would be white. Scar tissue doesn't stain blue. So the fact it's staining blue means it's herniation. You can see the back of the cage right there. I'm not going to mess with it too much. I'm just cleaning out the herniation and a little bit of bone spur right there. Pretty cool, huh?
We have a couple questions.
Sure.
This next one
You
comes
guys
from...
see the cage? It's metal. You see the metal right there?
We see it, yep.
Yeah, pretty cool. Yeah, all right, we'll take the questions.
This next question comes from Angelo Rivera on YouTube.
Okay, Angelo?
And they asked, a video of 2 surgeons on YouTube saying laser is no good. Have you seen it?
Have I seen the video?
Yeah, a video of 2 surgeons on YouTube saying laser is no good. Have you seen it, doctor?
I haven't necessarily seen that one. Maybe I did, maybe I didn't, but it doesn't matter. I don't believe them. I use a laser all the time. They're just lying to you is really the only way to put it. You know, there's a lot of myths out there, folks. I think people even say things about anesthesia, right? Like anesthesia's bad for you and you lose brain cells with anesthesia.
I just refer them to an acupuncturist.
Right, right. So, you know, There's a lot of misinformation, unfortunately, and I can't control it. But I don't know if I've seen that particular video. Was there a question you had about it?
He was just asking if you've seen it.
I don't recall. I don't waste my time, honestly, personally. I don't waste my time with, misinformation. I don't comment on it. I just leave it alone. That's why we do what we do. We show people the truth. You can't do these surgeries without the laser. It would be virtually impossible for me to do this. Oh man, look at that. The cage is loose. See it moving?
Yeah.
See it moving?
Yeah, we see it moving.
So it never fused. Now this is where all the pain's coming from, right here though. And I feel really good about it. We're cleaning it out. I'm hoping that even though it didn't fuse, his pain's gonna go away. All right. Well, we're just about done here. I need 30 seconds. Let me have this. Great questions, folks. Great questions. A little bit of bone there.
We do have one more question.
Sure.
This comes from Sheila on YouTube,
Hi, Sheila, again.
and they ask, can I request a different procedure?
You can request a different procedure, but your surgeon may not give it to you. They may not have a different procedure to offer you. That's why you gotta be careful about who you go to. Not all surgeons are equal, Sheila. Not even close. Not even remotely close. But if you want this done, you need to come to Florida. We'll do it for you. All right, 10 seconds. Let's show, see how the cage is moving, guys? See how loose it is? It's not gonna fall out or anything. See it wobbling there, how it moves right there? Like right there, you can kind of see it moving on the bone. Cage should not be moving. The fact that it's moving means that the bones are not fused. Despite the fact that he had the cage put in and he had the, I may need the laser back one more time, and he had the screws put in, screws and rods. It didn't fuse. I'm gonna tell him when I'm done it didn't fuse. I'm not gonna recommend any treatment for it because there's lots of people who don't fuse with their fusions, and you don't do anything about it unless everything is loose and moving around too much. But that's not a lot of movement. That's a little bit of movement, but with the fusion you won't see any movement, okay? So definitely already there's non-fusion. But we're pretty much done here. Let me just see this area right here. A little bit of more inflammation here. I'm hoping this fixes the problem. I think we're gonna get rid of 99% of his back pain with the laser surgery, despite the fact he has a failed fusion. Because we're doing the right treatment for him here at Deuk Spine. Let's show our audience the difference between the Deuk laser disc repair and the spinal fusion. Can you do that for me, Henry? We're gonna wrap this up and then I'll come and answer any more questions people might have.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement, whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
All right, I'm here with one of my patients who traveled from Australia to Florida to the Deuk Spine Institute for treatment. And you look happy today.
Yeah.
Yeah? Why are you so happy?
I'm happy because my back pain is gone.
Your back pain is
and
gone.
my leg pain is gone
Awesome.
from the disc. Yeah.
From the surgery yesterday.
Surgery yesterday. Yeah.
And you had the Deuk laser disc repair.
I had the Deuk laser disc repair. Yeah, that's right. Yeah.
So why did you come all the way to Florida from Australia for the Deuk laser disc repair?
I've been suffering from back pain and leg pain for nearly a year after an accident. So I did a lot of conservative treatment. Like.
Does my hair look good?
Yes, sir.
Oh, we're live?
Yeah.
Dr. Deuk Majan, we're just having some fun here in the studio and wrapping up our Deuk laser disc repair on a gentleman who's been suffering with back pain. I could swear he said 40 years in his history. He had a fusion done in Boston and obviously it didn't work. When I examined him, I saw that he was having pain in his lower back right where not the bottom of the fusion was, but where the top level of the fusion, the L4-5 was, plus above that at L3-4 and even L2-3. When I looked at his MRI, sure enough, he had annular tears at L2-3, 3, 4, 4, 5, and at 4-5 there was a cage on the left side, but there was some disc material behind the cage, like a herniated disc behind the cage, and I figured that may be causing inflammation. What I didn't expect to find was that at L4-5 the cage would be loose in the space there. And just to give you a better idea of what I'm talking about, I'm going to use this model. It shows you the screws and rods and the cage. So his cage wasn't exactly oriented in this way. The cage was actually further over to the left side, right around here in the foramen. And I came in like this with my laser and my scope, and I could see there was herniation behind the cage. I cleaned it out. I also pushed on the cage a little to see if it was loose, and sure enough, it was loose. Cages are not supposed to be loose after fusion. What happens when you fuse bones together is they fuse solid, with a solid piece of bone between them where the cage is. It surrounds the cage and engulfs it, and then those bones don't move at all. But his was moving a little bit. Now, does he need to refuse? I don't think so. I think that kind of micro movement is probably not going to cause any pain or symptoms for him. I think his pain was coming from the annular tear that was never dealt with properly. So I was able to test those 3 discs. There was 10 out of 10 pain at each of them except for the L4-5, which was a 9 out of 10. And more importantly, the pain was his typical pain that he gets in his back. So I feel the surgery was very successful. I think my patient's going to be very happy with his results. I think we're going to hit this out of the ballpark. All right, do we have any questions?
No current questions.
Great, you guys have been a great audience. Hopefully you enjoyed the surgery, and we'll be back again shortly with another patient with 2 bad discs in his lower back, annular tear, herniated disc, bulging disc. He's got a bulging disc at L4-5 and he's got a herniated disc at L5-S1. We're going to go in and fix